of Preventive Medicine at the University of Alberta. Today, we will be talking about how we are trying to work out what effect working on a wildfire has for Canadian wildland firefighters and the RPE challenges faced. And this photo here just is actually a photo I took at one of our sampling events at a fire in Alberta. Sorry, we're just having some technical difficulties here.
No, that's fine.
Okay. So our presentation will concentrate on 5 issues. Is smoke from wildland fires harmful to the lungs of the firefighter? Is respiration of smoke a route of entry for carcinogens? How can we assess whether RPE is effective in the field? How can we assess if RPE is acceptable to the firefighter? Can RPE use by wildland firefighters be mandated? Today, we will not be discussing the technical issues of RPE design or performance, however. In Canada, the vast majority of wildland firefighters use no RPE, and most are seasonal employees. The majority of our work we will be discussing today included wildland firefighters from Alberta in Western Canada. One of the major fire events included the Fort McMurray fire, which is located in the Athabasca oil sands in northern Alberta, as you can see in the top portion of the yellow on this map here. Our first question is whether smoke from wildland fires is harmful to the lungs of the firefighter. We were able to address this question first under extreme fire conditions during the Fort McMurray fire, where only structural firefighters from large cities used RPE. And next, for seasonal firefighters employed over successive seasons using a cohort of Alberta wildland firefighters followed for over 20 years who had no RPE. We are going to start with the data from the acute fire which happened in Fort McMurray some nearly 9 years ago now. So what evidence do we have from that fire on the effects on respiratory systems? We did a cohort study and followed an easy number to remember: 1,234 firefighters for over a 4-year follow-up period. We attempted to contact all Alberta-based firefighters, so this was not just wildland, but also structural, industrial, and wildland firefighters. We followed them 3 times at baseline, getting exposure and health data before the fire. We also were able to match firefighters to community controls in large health database. At our first follow-up, we concentrated mainly on mental health and supports. And the second follow-up, we had screening questionnaires for respiratory and mental health conditions. Finally, we did a clinical assessments of stratified subsamples estimating exposures in wildland firefighters. What we found was that firefighters deployed to the fire had more new onset asthma than community controls. This will be important again later in that Alberta, as in the whole in Canada, healthcare is free at the point of service and is universal healthcare. So we can use healthcare records kept by the government to look at questions like this. And using those, we did find that people deployed to the fire had more onset asthma than people who weren't deployed. Within the cohort, we found that exposure related based on estimates of exposures decrease in FEV1 and FVC from spirometry. And we found an exposure-related increase in positive methylcholine challenge, which is a measure of asthma-like symptoms, and bronchial wall thickening from clinical assessment. Our clinical assessment was based on what happened to firefighters in New York during the collapse of the towers. We concluded from the study that massive exposures during wildfire are associated with non-resolving respiratory damage. The second line of evidence we got, and this one is specific to wildland firefighters, we were able to set up a data linkage cohort in which we had records from wildland firefighters employed by the Alberta Wildfire Service. And we were able to link their exposures, which were recorded for every day of the fire season for each year from 1998 to 2022. We were able to relate those physician consultations under healthcare for the same period. We had nearly 13,000 wildland firefighters who were successfully matched to both exposure and health records, and we computed exposure indices. 3 exposures came out as important: how many hours they'd spent on sustained attack, which is people who were working on the ground over repeated shifts. Then complexity of the fire, which was recorded by the fire service. And also the type of employment, whether they were permanent or seasonal. We should say that in Canada, particularly Western Canada, almost all firefighters are seasonal. That means that they're employed at the beginning of each fire season and then laid off at the end of the fire season. And they don't usually wear respiratory protection. We were able to calculate cumulatively during the fire seasons and over successive fire seasons for these firefighters. And we adjusted, as you might expect, for sex, age, and First Nation status. We found that during the year of exposure, consultations for COPD, so chronic obstructive pulmonary disease, and pneumonia increased with hours of firefighting, both during the year of exposure and cumulatively over fire seasons. We also found that asthma increased with cumulative hours over multiple fire seasons. However, we didn't yet see any increased risk for cancer, but we had at most 22 years of follow-up and relatively 13,000, or a relatively small cohort. So we report that rather than draw conclusions from it, but we do conclude that wildland firefighters were at increased risk for non-malignant respiratory conditions with repeated exposures to wildfire smoke. So this answers one of our questions. Yes, they were at risk both from acute and repeated exposures to wildfire smoke. So next we asked ourselves whether respiratory protection might help protect from such effects and how we can assess if RPE is effective in the field. To do this, there needs to be an intervention study since there's no regular use to observe, and it needs to be a cluster randomized trial. Exposures include particulate mass and polycyclic aromatic hydrocarbons. Outcomes include respiratory symptoms, a biological monitor of exposure, such as urinary 1-hydroxypyrene or 1-HP, which is an indicator of PAH exposure that we can use to indicate whether masks are helpful in reducing exposures. So those who have got more 1-HP in their urine have been exposed, we felt, to more smoke absorbed through the lungs than people with lower 1-HP. And taking into account confounders such as PAH absorption through the skin and beard wearing. We conducted 3 of these intervention studies. In 2019, these interventions included either wearing an N95, a half face piece mask with organic vapor cartridge, or nothing. In 2021, we tested N95s versus none, and in 2023, we tested 3 different types of masks versus none. And here are photos of showing each of the 3 different types of masks tested in 2023. So mask X, which was a half-face respirator with a P100 multi-gas cartridge. Mask Y, which was a cloth mask with an alpaca filter. And mask C, which was a mesh fabric with a carbon filter. We found that cough, throat, and nose, but not eye symptoms, were significantly less bothersome in those randomly allocated to wear an N95 mask. We also concluded that those randomly allocated a mask had reduced 1-HP excretion. In our 2023 study of the 3 different masks, we found that among those without either beards or a failed fit test, Mask Z, that mesh mask, reduced end of shift 1-HP, where airborne PAH concentration was high. Another important question is how we can assess if RPE is acceptable to the firefighter wearing it. In 2023, during the 3-mask study, we found the amount of hours firefighters elected not to wear a mask increased from the first to third shift for all mask types. Mask Z, that mesh mask, was rated as more comfortable than the other types. Mask X, the half face, was rated highest on fit and perceived protection. Mask Y, the yellow fabric mask, however, gained the lowest ratings on fit, comfort, and feelings of protection. And here is just another photo of those 3 masks for reference. This is the question that now occupies us particularly, having shown that wildland smoke has an effect on the lungs and that wear and respiratory protection can reduce that effect. In our studies, when to wear a mask was always discretionary rather than mandatory. So we wanted to address the question of how we deal with respiratory protection in wildland firefighters, and it's difficult for a number of reasons. Others, including ourselves, have shown that RPE is measurably less effective in those who wear beards, and in Western Canada, approximately 50% of the men who are wildland firefighters wear beards, and it's not really feasible to employ only clean-shaven or only women, or demand that firefighters shave at the beginning of the season. Certainly, there is no agreement on the type of mask or which exposures should be prevented, and we have measured and tried different masks in our studies. There is a lack of masks meeting specified design and performance standards, so it may be that the best is the enemy of the good. And so the question that now occupies us is that if RPE is not mandatory, can we teach wildland firefighters to recognize when wearing it might be helpful? So if it is discretionary use, we want to be sure that they are using their discretion wisely about when choosing to wear one and making an informed decision. And this is currently what I am working on for my PhD. Okay, so our conclusions are from our 5 questions. Yes, we have found smoke from wildland fires to be harmful to the lungs of the firefighters, both during acute and repeated exposures. We also conclude that respiration of smoke is a route of entry for potential carcinogens. We also have concluded that we can assess whether RPE is effective in the field using well-designed intervention studies. And we can assess if RPE is acceptable to the firefighter using field studies and self-report questionnaires. Lastly, we conclude that RPE use by wildland firefighters probably can't be mandated, but it is an interesting topic for discussion. And just to finish up, we would like to acknowledge that the studies are funded by the Alberta government, Canada Wildfire, and both the Alberta and British Columbia Wildfire Service. And some references for any of those interested, and all of our studies presented here, you can find them published online as well. And thank you all very much for your time. And